So I'm moving to AFTAB Ahmed. AFTAB Ahmed is Assistant Professor, Critical Care Medicine, Mercer School of Medicine, Macon, Georgia. And I'm thankful to him that he's at work right now, but he spared some time for us. AFTAB.
Assalamualaikum. Thanks, Waqas. Waqas, can you bring my slides?
Okay, let me share slides. Okay, so, let me know when you can see the slides.
Yeah, definitely. So I think I'll start regardless. I'm just going to quickly touch the acute respiratory distress syndrome and very basic mode of mechanical ventilation. There seems like a lot of fear in Pakistan about ventilator. We just want to share that there's nothing scary about a ventilator. You can easily manage it. These will be the basics, and then you can definitely build on them. We can talk more about ventilator.
Okay, you can see the slides?
Yes. So first of all, it's very important to identify acute respiratory distress syndrome, because if you're going to use ventilator for ARDS, you need to be sure that this is ARDS, okay? There could be other things that you have to manage differently. So there's a standardized definition for that. It's called Berlin criteria. It says that the respiratory symptom onset should be within 1 week of a clinical insult, like let's say aspiration, you have pancreatitis, any reason that gives you a respiratory insult, okay? You need to have bilateral opacities on the chest X-ray. And that should not be an effusion, that should not be atelectasis or collapse, because those are managed differently. Then you have to have a PO2, FiO2 criteria. What is PO2? Basically, you draw blood gas and you see what's the partial pressure of oxygen there. FiO2 is what oxygen you're giving. Let's say the partial pressure is 100 and FiO2 is 100%. That would give you a PO2, FiO2 100 of 100. So you have mild, moderate, and severe ARDS. If PO2, FiO2 is less than 300, that's mild. If it's less than 200, but above 100, that's moderate. If you have less than 100, that's severe. And 120 or 150 is an important number to remember. I'll get back to that later. And it should be a non-cardiogenic opacities bilaterally. You can have pulmonary edema appearing like bilateral opacities, but that is managed with diuretics and like a cardiogenic edema. So you need to be sure that it's non-cardiogenic. And one of the things that you can do is get an echo, a bedside echo, make sure the ejection fraction is okay and all of that. Once you have determined it's ARDS, and then the patient is on a ventilator, there are multiple modes of ventilator. It's a very detailed discussion. We'll go over one basic mode. If you want to, let's say you are the person there, you don't have immediate help available, but you have a person on a ventilator, you can, this perhaps is the easiest mode to understand, the volume control. Now you will see in that volume control, there are 4 important things. F, you see there, that's the rate in green arrow. Waqas, keep the previous screen.
Okay, let me know when you want to move. Okay.
The tidal volume, then you have where it says O2, you have the oxygenation, the FiO2, and then you have the PEEP, the positive and expiratory pressure. So basically, these are the 4 very important numbers to remember. There's a lot of other numbers on the screen too that you see. A lot of them come by default when you put the ventilator on setting. But I'll get to the next slide why these 4 things are important. Waqas, can you move to the next slide?
Just a minute. I think there is something wrong with.
I can still continue without.
You continue. I'm trying to share. Okay.
Basically, one thing, the definitions that you need to understand clearly are the rate. What is the rate on the ventilator? That's the rate that ventilator is going to guarantee the patient. Let's say you set a rate of 20, the ventilator will give 20 breaths. Tidal volume is the volume that the ventilator will give on this volume control. You set 500, 400, that's the volume that ventilator is going to give in 1 breath. What is the FiO2? That's the percentage of oxygen in that breath. So you can keep it 21%, 100%, when can go up to 100% like pure oxygen. What's the PEEP, the positive and expiratory pressure? That's a sustained pressure that you have, the ventilator will keep to keep the lungs open, okay? And that you can also dial in on this volume control mode. And we'll discuss a little bit more about this in the next slide. The PEEP is important for oxygenation. And then ventilator gives a positive pressure breath. So what is peak pressure? Peak pressure is the full pressure that ventilator has delivered with each breath. So it will involve all the pressure that is transmitted through the endotracheal tube all the way down to the lungs. So if your airway resistance is high, if you have a clot in the ET tube, or if you have clogged ET tube, that the peak pressure will go high. That's why plateau pressure is more important, because that's the pressure that is reaching the lungs. So how you calculate that plateau pressure, a lot of ventilators will auto-calculate, but to accurately calculate, you do the end inspiratory hold for a second, and it will give you what what pressure in a static environment the lung is feeling, because the more the pressure, the more the chances of lung injury. And the number you need to remember on plateau pressure is try to keep it below 30. Driving pressure is similar concept. Basically, it's plateau pressure minus PEEP, and you want to keep that number below 15. Intrinsic PEEP is important to remember. If somebody you're not giving enough time to exhale the breaths out, the air will keep trapping in the lungs, and they will develop the intrinsic PEEP. You can do an expiratory hold maneuver to see if that's the problem. Because if you develop a lot of intrinsic PEEP, that is going to affect your all the ventilator mechanics. And it can also cause hemodynamic compromise. And the way to get rid of intrinsic PEEP is just to disconnect the circuit for some time, let all the air blow out, and then reconnect it. Okay, I think the next slide is where we will have more detailed discussion on managing this volume control. So basically, the easiest way to remember is, it's way more complex than that. The goal is to simplify it as much as possible. How do you
oxygenate? This is the slide?
Yes.
Okay.
So how do you oxygenate the patient on a ventilator? Pretty much everything comes into play, but the main things are PEEP and FiO2. You can up-titrate FiO2 to give more oxygen. You can up-titrate PEEP to give more positive and expiratory pressure. You open up more lungs, and they can participate in gas exchange. But you cannot overdo it. If you over-distend the lung, then there will be shunting. The next thing is ventilation, means how to get rid of carbon dioxide. You have your tidal volume. You increase the tidal volume, you'll have more breath volumes. You can blow it out. You can increase the rate. Now let me tell you how you interplay all of this. What are your goals on ARDS? You don't want to injure the lung that is already injured, okay? So you don't want to give a lot of unnecessary pressure. You want to optimize your pressure. Your key thing is oxygenation. So generally, remember one thing: whenever you intubate somebody, you have to know their minute ventilation. What was it? What's their approximate minute ventilation before you intubated them? Because then when you sedate them, you cannot suddenly decrease their minute ventilation from 20 to 10. You initially match it, and then you slowly start taking control over the vent. So you can, by reflex, go up to a FiO2 of 100%. That's fine when you initially intubate. And then you start optimizing your PEEP. So always remember that without PEEP, ventilator can be actually dangerous, because you cannot have a lot of atelectasis and then try to give positive pressure vent. So you need a good PEEP. What you can remember is you can start with 6, 8, 10, and then slowly start going up on it, okay? And how, if you have to oversimplify it, how will you know you have reached your optimal PEEP? If you're keeping your plateau pressure less than 30, you have room to go up. So set your tidal volume at 6 cc per kg. Again, once you have to control over the ventilator, okay? Like you initially match their minute ventilation, but then 6 cc per kg ideal body weight. Calculate their ideal body weight with their gender, height, and weight, and then multiply that with 6. That would be your tidal volume. And then that volume vent is gonna need to generate some pressures, okay? So that's where the plateau pressure kicks in. Keep titrating your PEEP up. If your plateau pressure is staying less than 30, most likely you are on the optimal part of the pressure volume curve, and your PEEP is helping recruit more and more lungs. And then let's say your PEEP is still, you don't think it's optimized. There's a big patient, you need to give more PEEP. You can drop the tidal volume a little bit. That will drop the plateau pressure, and then you can up titrate your PEEP. And then you can follow the high PEEP, low FiO2 oxygen table. You can easily Google it and titrate your PEEP and FiO2 accordingly. Ventilation, we have discussed. That's the key part, is that you need to keep carbon dioxide in control, but you don't have to strictly control it. There's a thing called permissive hypercapnia. You can sacrifice a little bit of tidal volume. You can keep your CO2 close to 60, pH above 7.2, that's fine. The next thing is sedation and paralysis. So sedation is very important. Ventilator can be dangerous without appropriate sedation. You don't want the patient and ventilator to be dissynchronous with each other. You need synchrony. So you sedate them, again, depending upon what medicine you have available. You can follow the Richmond agitation scoring system. Keep it close to like -1. If the ARDS is progressing, that's when you have to completely sedate them. Remember, that's very helpful. Once the ARDS approaches severe category, the PO2 effort is less than 150 or 120, just deeply sedate, almost medically induced coma. And then when it's below 120, you should paralyze them too. And again, you need to make sure that your hospital has adequate monitoring measures. You cannot have somebody paralyzed without adequate sedation. So they should be adequately sedated. You need to have monitoring. Some hospitals have BIS monitor or something. And then paralysis, you can do the train of force, the twitching method, whatever your local hospital has, make sure that they're adequately paralyzed. Sedation and paralysis is going to help you take over the control of your ventilator, and then it will also decrease the dyssynchrony, and you can optimize your pressures and settings. Next thing is proning. Try to establish a proning protocol in your hospitals. It's not that difficult. From what I have spoken to my colleagues in Pakistan, proning is not being done in ventilated patients. You need to have a good team. Somebody needs to, like, there are YouTube videos and everything. You basically need 4 or 5 people. One person is going to watch the lines. Somebody's going to make sure the ET tube doesn't get displaced, and you need few people to flip them over on their stomach. You keep them like this for like 16 hours, 8 hours flat. And then if you see their PO2 FiO2 is still was responsive to proning, but when you put them supine, they're again starting to desaturate, you again do it for 16 hours, and you can do multiple cycles. The next
AFTAB, I'm sorry, I'm interrupting you. I would like you to here just explain in briefly how proning helps with the sick lungs in COVID, because this is something not being done in Pakistan, and we really have to give emphasis on it. So if you can just let our people know how actually it really helps.
So basically, when you're proning, you're putting them on their stomach, right? You have more dependent, in ARDS, you have more dependent collection on the posterior side. So you're basically now even out displacing all the inflammatory fluid that was in the lungs, okay? So you have created a more lung that is going to participate. You have moved the heart away from the lungs too, okay? And basically, if I have to put it in one word, you have decreased a lot of shunting that is happening. You have more lungs available to interact with the oxygen, and then you don't need those aggressive settings on the ventilator. And then again, the thing is that on a ventilator, you cannot keep somebody on ventilator for a very long time on high pressure and expect the lungs to heal. You have to do every maneuver possible to make sure you're giving minimal settings on the ventilator and allowing time for the lungs to heal. So that's where proning comes in. It helps you keep the lower ventilator settings, gives more time to the lungs to heal. So please make sure if you can work on proning protocols in your hospitals, that is going to help a lot. I'm telling you, this is one of the things that decreases mortality based on studies. So this is important as you guys move forward in the COVID-19 pandemic. More and more patients will need ventilator. Have a proning protocol in your hospital. It's a simple, no cost almost, and one of the most effective measures to help. Next thing is steroids. Again, you can use the DEXA ARDS steroid protocol. You can use the Meduri hydrocortisone solomedrol protocol, whichever you prefer. DEXA is the latest one. A lot of intensivists are using that, and that is, remember, different from the DEXA COVID, the study that came from UK. That is pretty much used. They use it on pretty much all the patients. The steroid protocol for ARDS is very specific, so make sure you use this if your institution has a protocol when you're using them for ARDS. The monitoring, I'll tell you some simple things about the monitoring. Remember this thing: whenever you make a change on the ventilator, see how that change affected their plateau pressure, their peak pressure. Okay, remember these two things. If you made a change, let's say you increase the tidal volume and the plateau pressure shot up from 28 to 36, there's something that you need to see. The lungs are maybe not that compliant to afford that tidal volume. The other thing is rule of thumb. Again, this is a little bit oversimplification, but remember, whenever you have made a ventilator change, it's safe to get a blood gas in 1 hour, and just to see the effects of those changes, and that will help you guide moving forward. Let's say you have seen improvement or deterioration or steady state, that will help you guide how to keep on making further ventilator changes. And I'll have to leave here, but I'll tell you one thing, that we are all, whenever we are not on service, whenever we have off time, we are available to answer any questions. I think Vikas is going to work on that to see if we can do like ventilator consults, help you guys answer the ventilator questions. I think one thing in US training for critical care is there is heavy emphasis on, you pretty much spend years learning ventilator, so you become more and more comfortable. We will be, from whatever we know, we'll be available to help you guys. The goal is that hopefully take that fear of ventilator. We have been hearing that ventilator, anybody going on ventilator is not coming back. It's not the fault of ventilator. Once we learn how to manage it correctly, it's gonna be helpful. And on that note, Waqas, I will leave, and I'll have Waqas and Talha and Farooq and all of you take it from here on.
Thank you very much, AFTAB, for sparing some time. And I know you were working, but thank you very much. And yes.